I wanted to start this lecture by sharing a piece that I wrote for DVM 360 about this lecture. I've given this lecture so many times. I've given it all over the world. I've given it in Spanish, in English, and it's something that is very near and dear to me. So here is the journal article. I've timed myself as 3 minutes, 4 minutes, and then we'll get started. So how it all started. And I want to preface this by saying I wrote this 2 years ago when I was the director of critical care. If someone had asked me in 2011 whether I'd one day be the clinical director of critical care and emergency, I probably would have laughed and said, not a chance. At the time, I was working in general practice, where I spent 6 years honing essential skills such as client communication and catheter placement. I still remember my first day of externship vividly, racing up the FDR highway in a yellow cab, the New York City skyline behind me, and the towering 8-story, I think it's now 9-story, 8-story Schwartzman Animal Medical Center of New York growing larger as I approached. The moment I stepped inside, I knew my career was about to change. My mentor at the time, Brandy Alexander, for any of you who are OGs, was a highly skilled technician who exuded confidence, especially in a crisis. She commanded the room with her presence, making split-second decisions that saved lives. Before I finished my externship, or VTI program, which is a wonderful program that we have at the AMC, she gave me a piece of advice that would stay with me forever. If you can place a catheter in a dying animal, you can do anything. Sadly, she left the field due to burnout, transitioning to human nursing. We know a lot of people have done that, right? But her impact on my career was profound. During my externship, I rotated through various specialties, quickly realizing that ECC was reserved for only the most experienced technicians, meaning I couldn't work in there. The intensity, the pace, the responsibility was both thrilling and daunting. It took me a full year after my externship to summon the courage to cross-train in critical care. But once I did, there was no turning back. Hurricane Sandy was a turning point in my career. A lot of New Yorkers here? Remember that time? Yeah. As Lower Manhattan disappeared underwater and the East River surged into our first floor, our ER was flooded, not just with water, but with sick and injured pets arriving in drones. Although we still have a lot of flooding now, so it's not construction. When I heard the overhead page, help to the ER, help to the ER, anybody with hands, help to the ER, I didn't hesitate. That is literally what they said. I ran downstairs from the 8th floor, ready to do whatever was needed. When I arrived, I saw the head of the department, Dr. Jennifer Pretty. Her presence was both inspiring and nerve-wracking. It was her who paged. But there was no time to dwell on it. We were busy. The ER was in full crisis mode and instinct took over. That day was a blur. I placed over 30 catheters running between cases and responding to countless codes. But amidst the chaos, something clicked. This was where I was meant to be. That moment launched my journey in critical care, leading me to years of overnight shifts. Right, Sam? Overnights. Mentorship roles, my promotion to team leader. Right, Nance? Earning my VTS in emergency and critical care. Oh man, that was really hard. Becoming an international speaker. That was even harder. Dipping my toes into corporate veterinary medicine. We won't talk about that, but I did leave for 2 years. Becoming a recover instructor, so I'm a recover instructor as well, and ultimately coming back as the critical care and radiology clinical director, and now as the senior director of Peri-Operative services. Now, more than a decade later, I believe that critical care is a place where every technician can find both a purpose and a home. Eat or be eaten, thriving in critical care. Critical care is an intense and demanding environment, especially for newer technicians. I have trained countless technicians. Strong mentorship is key to success. I highly encourage you to join Rick's next lecture because it is so true. And while I didn't have a designated critical care mentor, I had something just as valuable, an entire hospital willing to teach me. Assistants, client service reps, technicians, residents, staff doctors, and even clients all played a role in shaping my learning. As a leader, I've come to understand the importance of fostering a psychologically safe environment for mentorship. Preceptors, additionally, must have a strong emotional intelligence and a deep understanding of adult learning principles, allowing them to adjust their teaching approach based on each mentee's need. Everyone learns differently. But mentorship in critical care is not just about support, it's also about knowing when to apply just the right amount of pressure. I always think about someone who mentored me in critical care when I say that, Amy Linhart, because she always knew when to apply the right amount of pressure to get me to do the things I needed to do. Providing proper introductions, pairing staff with the right mentors, and ensuring trainers have the tools they need are critical steps in building a culture of learning, resilience, and longevity in the profession. These are the things they just don't talk about in tech school, right? Being a culture champion of the ICU. I'm often asked whether I prefer the ICU or the ER. My answer is always the same. I go where I'm needed. It's ICU. While I appreciate both, the ICU holds a special place in my heart. I believe it cultivates essential skills like time management, effective communication, mentorship, camaraderie, and resilience, qualities that extend far beyond being a technician at a clinic. When technicians hesitate to work in the ICU, it is often due to stress or a lack of confidence in handling critical patient care events. So my goal in having this discussion with you guys is to change that perspective by introducing structured algorithms or tips and training approaches. I aim to show you that it's not just a high-pressure environment, it's also a space where you can learn so much about yourself and be the best medical professional you can be. Oh, there you go. So critical care, this is me circa 2014 in our very old ICU. Look at me, so fresh. So critical care demands focus, quick decision-making, and the ability to act under pressure. And technicians are a huge part of the team. I don't actually need this anymore, so I'm gonna move this. That's my dog. I don't need this anymore. Ah, wow, I really skipped ahead. Yep, so technicians are a super important part of the team. And when it comes to our responsibilities, there's the obviously completing treatments, doing TPRs, administering medications, but the less obvious is your responsibility in monitoring parameters, right? You're spending the whole 12-hour shift with that patient. You know exactly what it looked like at the beginning of your shift. You know the changes towards the end. And that kind of stuff yes, numbers are valuable, but a lot of times something just doesn't feel right. And it is our responsibility and role when we are managing a full ICU. For example, our ICU, I think, holds 42 animals now, 44? Yeah. When you have that many patients and you have all the staff in the world and you have a busy ER, it's important to know what you're doing and to develop that pattern recognition. So when you do find that something's wrong, it is also important to be able to communicate that efficiently and effectively with your doctors. So why am I talking about algorithms or tips? Same thing. Well, it's important. It's important for us because it will help us feel prepared, we'll be successful in the patient care we provide, it'll improve our medical quality, and then most importantly is consistency. So I want to, as you can tell, we're all very interactive teachers, so I'm going to ask you questions throughout this lecture as well. But I want to ask you guys, for those who have worked in the ICU or for those who have never stepped foot in, you know what they look like, right, from TV. When you walk in, what's the first thing that comes to mind? Chaos. Who said chaos? Oh, I love it. I'm just like, where do you need me? What do you need? It's scary, right? Was a lot of what I was sharing resonate why you're maybe like, I don't know if I want to go to ICU? Seems like a lot, right? What else do you think about? Some people say running home. Some people say, let me at it. That's Liz Rush. She's like, let's go. Anyone else? What's that? Pumps. What's beeping? Why is it beeping, right? Yeah, it's a lot. Your brain goes all over the place because it is chaos. This is one of my favorite pictures. Oh yeah, I think Sam's in there. This is what our old ICU used to look like. And whenever I feel sad or I hear complaints about no space, I'm like, do you guys remember what it used to be? They were filled cages, crates on the floor, pure chaos. If you have not seen the new ICU, I encourage you to come take a look. We've been through a lot. But yeah, it's a lot. And if you are a visual learner, right? If you're a visual person coming and you're just like, I don't even know where to go, right? I don't like disorganization. My brain just hates it. It loves algorithms, which is why I love this lecture so much. But situational awareness is the thing I want to talk about here. Just scanning the environment, looking at the equipment and patients for safety, stability, and organization. I know for myself, I'm going to walk in and scan around to see if anyone, Frenchies, are like, right? or if animals are upside down. I just want to know what's going on before I dive in. Now, here's my dog Phoenix. He's the best. Everybody say, aw, aw. So the lecture I talk about, like I said, is tips or an algorithm. And the first one is initial triage and stabilization. Actually, before I go into this, I don't know why I have it set up like this. The reason I came up with this was because I wanted to write a love letter as I was departing ICU. But also, I had a technician that I was training, or that I hired, and I had paired her with many trainers for many months. And you know, she was so good, but there was just something that she was struggling with, and she just couldn't get to a point where we felt confident to release her, because we also don't release you unless you're ready at AMC. No matter what department you're in, you're not released until you're ready. And that is a wonderful benefit of working at the AMC. So I tried many trainers. I had Samantha train her, myself, and I was the last person to say, all right, let me see what I can do. Not that I feel like I'm any different from any of our other wonderful trainers, but I was like, let me just see. So I sat with her and I took a piece of paper. It was like an overnight that I worked with her. And I was like, all right, talk to me. What comes to your mind when you walk into this room? And little by little, she created the algorithm. The way her mind, what she said came out in her mind of what she was thinking about, these were all the things, and I just plugged it into what made sense, because I'm an organized kind of person. And it worked. It worked because through that, we were able to have discussion points about what each one means and why it's important. And anyone that I hired after that, this lecture that I'm giving you guys was a mandatory part of the onboarding process for them. So they understood expectations of what it meant to be an ICU tech, and they felt confident in at least having some sort of structure, right? So the first one is initial triage and stabilization, catheters and indwelling devices, IV therapies, trending blood work, monitoring vitals, pain score and management, meditation and ambulation, which Samantha did a really amazing job in going really deep into that. I'm not going to talk at the same level. Nutrition, which we also mentioned as well. Where's there? Oops. Going home, which is always our favorite part because it's so busy, and as soon as you empty the cage, the next animal comes right in, especially from neuro. And then TLC. All right, so before we jump in to the tips, oh yeah, Freya and Sam's there. You're in a lot of my lectures, I don't know why. So triage, everything starts with the triage, whether you're a technician, whether you're a practice manager, whether you're a director coming into work, you gotta figure out where's the fire. Where do I need to go to first? Well, AMC is no different. We have a veterinary triage list that we use, which is this template over here, and it is based, it's a smaller version of the Manchester triage list, and it basically just helps us communicate with clients how long is the wait going to be. It doesn't mean that we're, like if a patient is a category yellow, which says the wait's less than an hour, it does not mean that our team is not already actively working on them. It just gives the clients like, all right, we're gonna come talk to you in an hour, but give us permission to do the things. We also created a fast track urgent care department. I don't know how to explain it really. Many years ago, especially when we were having people wait 4 hours for like an ear infection, it doesn't seem like it's an emergency, but I know we all have pets and everything seems like an emergency. So we were able to create that system, which was very successful. So I always like to mention it. But talking about the ICU admission, there are 3 different ways that animals make it into the ICU. They're either coming in through the emergency room at AMC, they're either coming in through a specialty appointment, so it could be a post-op surgical case, a internal medicine appointment that they did some diagnostics and we said, oh, no, you're kind of sick, we gotta stay in the ICU. Or a referral, that's all of you guys, right? You see clients and patients at your clinics and you realize they just need some advanced care, so they come in and then they're admitted to the ICU. Either way, that's how they get in there. I want to talk a little bit about our triage list in case you have not seen them before. So because we are a level 1 trauma center, we do utilize this list for any animal that comes in that has experienced a trauma. And it's basically, you look at different areas such as perfusion, respiratory, neurologic. It's pretty self-explanatory. You read it, you give it a number, and the number tells you, yay, you're getting out of here, or the number says, bad news bears, you're not getting out of here. So this will help you identify which patient do I need to go to first. So if you don't have pictures of that, take pictures of that. Then now that we've talked a little bit about triage, I also just want to briefly discuss the primary survey. So every technician should be comfortable performing a physical exam on any patient, whether it's coming in for vaccines, whether it's coming in for a spay. You should be comfortable looking at the four main systems, which we learned are respiratory, cardiovascular, neurologic, and urinary. Know what your normals are, what your abnormals are. And then there's everything else in between, right? Vitals. So you may not know offhand well, you're gonna know a Frenchie is 109 degrees, but you may not know that a cat is, I always tease Frenchies, it's a constant joke, so just so you know. You're not gonna know that a cat's 106, right? You're gonna have to take vitals. So that's all the in-between. And then visual inspection. If I'm walking into the triage room and I see a dog with a huge belly, I don't really need to sit there for 2 minutes and look at or listen to the vitals. I'm just gonna tell the client, hey, I think something's going on. Do you mind if whatever your protocol is at your hospital? Because you can tell that they have a big belly and there's probably something fun in there for surgery to cut. And that's me now, so. Okay, and then I got this list here from Silverstein. It's just a triage algorithm for what to look at for each system. So if you're a trainer at your clinic, which I assume a lot of you are because you're here nerding out with us today, this is a good reference for you to give your newer technicians so they can become more confident in their physical assessment. All right, so let's jump into it. So number one, so I like to start off with the tip, so the punchline. So tip number one is so you're an ICU tech, this is the scenario, you're in it, you're working, you're taking in patients. And the first tip I tell you is to ask whoever's rounding you, what's the treatment plan, right? I always explain to the technicians, you're not robots, you're not just doing treatments all day long. There has to be some sort of plan in place. Is the plan that I'm waiting for that the patient was seen through, the ER, and now we're waiting for an ultrasound and it's painful, so we're managing its pain. Okay, sounds good. So you always have to know what you're doing and why you're doing it, so it doesn't feel like you're doing an endless cycle of work. And I know it can feel that way because I've lived it and I've done that. So giving your work meaning and purpose. So I have here some frameworks. This is very small. What did I write here? It's a little hard to see from this angle. So the first framework is getting initial triage and stabilization. So finding out, how did this patient end up in your ICU? Did they sign hospitalization forms? Do you have a code status? The work that we do is very expensive. We want to make sure that the proper paperwork has been processed. Sometimes in our ICU, animals bypass that. I think it's gotten better, but it used to just be that animals would just get dumped into ICU. And then we'd find out after the fact, oh, wait. Medical history, that's important. Does this animal have diabetes, but it's not even here for that? It was here for a hit by car, or it's here because it is vomiting randomly. It's important to know your history. What did it come in for? So I asked, what's the history? Just brief, 3-day history of vomiting with some hematochezia. Owners went to the RDVM, gave some supportive care, still not eating, whatever. And any, like I said, existing comorbidities. Ugh, I feel like you, Sam. And then what a potential diagnosis. Oh, we're treating it for AHD. What do we call HD now? Acute hemorrhagic diarrhea syndrome? Yeah, AHDS. Just so you have an idea of what you're dealing with. So the initial assessment, I'm going to ask the technician who's handing the patient to me or the doctor, what are the vitals? That's important to know. So you have a baseline. Was the animal painful so that when I go into the cage to pick up the chihuahua, it doesn't bite me? Because they only bite when they're painful. They're otherwise angels. I want to know what catheters are placed. You have some colleagues that like to place back leg catheters with furry animals. It's important to know that. What blood work was done. We went over that in Daniela's lecture. Blood work is so important. You need to know if this animal was hypoglycemic. So much happens from the ER to the ICU that perhaps the bolus was missed or perhaps the doctors didn't see the blood work. So you want to see it and know if there were any abnormalities. You want to know if the animals received fluid therapy. Did they receive a bolus? Which means they probably purchased that fluid bag, so you don't have to open up a brand new one. Initial and treatment plan. Yep, so what are we waiting for kind of thing. And I just highlighted here, did you get a code? Because that's so important, right? BLS, ALS, all that stuff is a lot of work and a lot of money to clients. So we want to make sure that we understand what the client's financial and personal wishes are for their pet if something were to happen. And if they're coming into your ICU, you need a code. That should just be a protocol for wherever you work. All right, so tip number two is to take a picture. So I'm going to talk about catheters and indwelling devices. The first that comes to mind is IV catheters. So like I said, I want to ask the person that's giving me the animal, or even if I'm taking over for another shift, what kind of catheters do we have? Peripheral, arterial, central lines. When was it placed? Were there drugs needed? If it was a Frenchie who was trying to murder you, did you need to sedate it to give it a catheter? Was it a very hard stick? I think we're all still pretty bad about documenting how many times we had to poke an animal to get a catheter. We all know the 2-poke rule, but we also know real life that sometimes it does take a lot of sticks, and I don't think we're really good at documenting that stuff. So it really sets up the next person for failure, right? What else? Functionality, positioning. Is it somewhat working? Is it not working? Is it patent, but it doesn't give you blood back? What do I have here? How many do you have, etc. Or why do you have this type of catheter? I think I had a slide in here previously about, I guess I don't have it anymore. I used to ask people, like, what's your reason that we would immediately place just a jugular catheter in an animal instead of a peripheral? What are some case presentations where we might go to that? Does anyone know? Trauma on the legs, yep. So like fractures, right? What else do we see a lot of, unfortunately, in New York? Like burn victims, right? So asking questions like that is important as well. Okay, so something that we utilize in our treatment sheets is a phlebitis score. Are you familiar with this? It's important to add to your medical records if you have inpatients. It's fairly easy to follow. I don't think I can see it from here, but what I assume it says is 0 is normal and that 4 is super painful. There's probably fluid coming out of the insertion site. It's important for you guys to add this to your medical records if you can. Who has electronic medical records in their facility? Who still has paper? Okay, either way, you could write it in or you could have the system alter it. It's good for you to notice and record it every 6 hours. And if you're unsure, if you're a new technician or you don't know if your eyes are messing with you, take a picture at the beginning of your shift and then take another picture 8 hours in and you'll be able to tell the difference. I worked a shift the other night, well, I shouldn't say this, but I worked a shift and I was looking at the patient and I saw that one leg looked like that, but it had a catheter in it. And then I saw the other leg, which was that leg, that looked pretty terrible. I should have taken the picture of the catheter, but I saw that the phlebitis score was 0, which I didn't think was really true, right? It probably should have been a 1 or a 2. But unfortunately, this dog was neurologic and had many catheters in many areas, so I understand the reason why, and it could not receive a central line itch jug. But we still got to watch it. Anytime I gave it drugs, it was like, I hate you, which made me feel horrible. But I think that dog I saw it a few days later and it was doing a lot better. So that was good. So this chart I got online, so you can go ahead and get that and stick it in your ward, stick it in your hospitals. Education is key. So why is this important? Well, this picture is courtesy of Sam. Because if we don't break down central lines that are wrapped very nicely with cast padding, we don't verify that things are patent, and we're giving these animals pretty caustic drugs like potassium, high levels of potassium, dextrose, this is what happens. So this catheter was not rewrapped. This was not from our hospital, but we ended up receiving that animal, right, Sam? And that was the result of it because it was on a dextrose CRI, and the catheter was not being maintained as good as it should have been. Oh, there you go. I know, it's pretty horrible, right? That dog did fine, I think, right? Yeah. All right, so I'm still at, tip number 1. So what are some other indwelling devices that I care about in the ICU? Yeah, of course I care about catheters, but I also care about high-risk devices like anything that goes in the trachea and the chest tube, anything that the animal was not born with. So I'm gonna wanna know when I'm getting rounds, does this animal have a chest tube? Or if this animal's on the ventilator, that's important for me to know. In fact, if I'm taking over a ventilator animal, I'm probably gonna round very quietly right next to the animal, because rounding in the hallway when my back turned to the animal, that's not, how long rounds take, right? That's a disservice to the pet. So this is just important to also document. So you wanna understand how the site looks. Do you have replacement equipment in the event you have to replace a trach tube right away? How has the animal been tolerating trach care? All sorts of things. If you are in a hospital that is just starting to see patients like this, I highly encourage you to incorporate a level system. We have a level 1 to 3 system in our ICU. This is definitely not a level 1 patient because it takes so much labor to be able to provide this level of care. And you should be paid what you know, for the work that you're doing. I think this audio will work, but this is a bulldog.
And if it doesn't work today, then we'll get airway.
That his little trach tube. It was great. I think I've worked on hundreds of these. I've actually lost count. Anybody work with trachs and Frenchies and bulldogs in their clinics? Anyone deal with heat stroke Frenchies and bulldogs? Yeah, this is what happens to them a lot of times. And even now that I'm working in surgery land, a lot of these are planned, which has been an adjustment for me because I'm so used to going like this with like Jen Pretty and the blade. Let's go. And I'm like, wait, this is planned? And they're like, yes, this is planned. This is what we're doing in addition to our BOAS procedure. So that has been an adjustment for me. I'm like, okay, all right, well, I know how to wake them up. What are some other indwelling devices? Urinary catheters. This is important. You want to know if your animals have subs placed. Subs are under the skin in the body. And we know that we can't grab these animals by their belly because we could dislodge the hard wire that's in there. I also want to just specifically point out the cystotomy tube here because I did have an incident many years ago where this animal was living with cystotomy for whatever reason and really was supposed to be living with an e-collar its whole life. Again, we don't choose the situations for these pets. It's whatever shows up into our ICU. And unfortunately, we were not rounded about its cystotomy tube because it wasn't here for that. That was just a part of its everyday life. And the e-collar came off, and then we turned around and the dog had ripped out its cystotomy tube. So that's why it's important to ask, if you're not gonna say, can you tell me if this animal has a cystotomy tube? But you're going to ask during your rounds, is this dog going outside to walk? When's the last time it's peed? When did you change the cat's litter box? And making sure you're documenting those kind of things. Okay, number 3, IV therapies. I think, where's my tip there? Did I leave it? Yeah, that's tip number 3. And I'll go back. So tip number 3 is to check every pump, label every pump, charge every pump. I'm gonna go back a little bit. So the list that I go down when I'm rounding is I ask them, are they on fluids? What type? LRS, P-Lite, saline? What additives are on there? 20K, whatever, K-Max, magnesium, phosphorus. What blood products is the pet on? How long has it been receiving transfusions? Is it on any CRIs? Is it on IV nutrition? Is it on antibiotics? If the animal's on Unison versus meropenem, that's really important to know because those are 3rd generation antibiotics, which means this animal maybe has something that I could get or the staff could get. So this is a long list of things that you could ask. I want to say that now with the advancement of our ICU and our electronic medical record system, we don't see a lot of errors in how things are inputted. Like we can track this very easily, what the rate was for the norepi. However, I will still walk into an ICU and animals are on the wrong fluids, on the wrong additives, on the wrong everything. Things are not labeled. So that stuff, it's never going to be replaced by AI or technology. Can't replace the human in that sense. So I encourage you, don't just assume that it's all right. Just don't. Do the work yourself and make sure that everything's labeled appropriately. So I have a little checklist here for the IV pump. So pump checks. I was taught by my first manager, Teresa Kilikowski, for any of you who remember her, to plug everything in. She would just walk into the ICU and just plug everything in, and I do the same exact thing because it drives me insane when I hear bumps peeping. I also close all the pumps too because she told me they used to mess with the centers. Make sure that they're all labeled for easy identification. Make sure that the lines aren't trapped in the cages. If you have a lot of lovely interns like we do, they love to close the lines on cages. Have you guys ever dealt with that with doctors? Yeah. Unfortunately, I've walked into situations where the fluid was put the other way. And so I see all this blood in the line and I'm like, what's going on? Honestly, when people are so stressed and so busy, these things happen. So it's not intentional, but it's good to just, I'm looking at the catheter and then I'm looking at the fluid bag and I'm just doing that whole check, right? Verifying the fluids, I'm not gonna repeat that, but same thing for CRIs, getting the formulation, dose rate, diluent concentrations. And if your pet is on things like norepi, as I'm getting rounds, the first thing I think about is this animal on a blood pressure monitoring machine, right? So things like that. There's some other things that we give to our patients in the ICU, blood products, lipid. Does anyone use lipid here? You guys familiar with it? Yeah. For toxicities, go ahead. Oh yeah, sure. Yeah, and I'm happy to email this to anyone who wants it, yeah. Lipid, So fun fact about lipid. Lipid is great, but lipid can also have some detrimental effects on your patient. It can cause lipemia. So usually once it's being given, we sign up a spot check PCV to make sure that it's not having those impacts. And lipemia in the blood has effects on the brain. We're not going to go into that, but it's not good. And then blood products, we want to make sure that we're giving the blood at an appropriate time frame. So some questions that I just ad hoc ask, depending on what I'm talking about, is antibiotics. I'm educating myself on what generation it is, expiration. Our protocols are very specific. There are certain drugs that are only good for 72 hours, only good for 17 hours. And a lot of times when you're running around and I don't have time, I don't have a Sharpie, it doesn't get labeled. So there's two things that happen there. Either the animal is still getting this bottle of, cefazolin that who knows when it was made, or a good tech is throwing it away, but then that's just wasteful, right? Compatibility. I hope you guys have drug compatibility books in your clinics, because there are a lot of drugs that cannot be given at the same time. They can't be given within a certain time frame. All that information your doctor should be aware of, but sometimes things slip through the cracks when you have new grads. Blood products, like I mentioned, knowing if you have a cat, type A, type B, type AB, dogs, that kind of stuff. Pressors, monitoring, phlebitis. So pressors will cause the same effects that was on that little Yorkshire on the photo that we had. Signage, right? A sign that says "Do not flush," no epi. I can count on my hands how many times interns have just flushed the T-port, and then you look at the ECG and there's a nice little arrhythmia because the norepi went in too fast. Recent blood work. So if I have a patient that's on 40K and I'm hour 6 into my shift and I realize that we haven't done any blood work, I'm going to help my team and say, I just want to make sure we have a recheck point of care blood work signed up. So be that advocate for your patient. And you'll see sometimes we'll recheck it and the potassium's like corrected itself well over. Side effects. What else? Fluid expiration. So same thing. I think we have a rule at our hospital where the fluids are only good for three days. Forgive me if I'm wrong for that. Nutrition. So the Peri-Operative that Samantha was mentioning before, that's only good for 24 hours. So it's very important that's labeled. It needs to be maintained sterilely, has its own dedicated catheter. So all that signage needs to happen, especially when you have a care team like at our hospital where any patient is attached, like say it's internal medicine, to like at least 20 people, residents, interns, staff doctors, technicians, plus our team. So the more labels, the better. And then pain meds. So just remembering your 5 Rs. We've all been there. We've all given the wrong medications, But if you're asking during your rounds, what medication is my patient on? Hopefully that's a stop block for you to be like, oh wait, why am I giving this Pimo? He's not here for heart stuff. And then you realize, oh, it was the wrong patient. And then you didn't give it because you're good techs. Trending blood work. So tip number 4, similar. So it's actually really nice that Daniela had this wonderful lecture because it is so important for you to know a few key blood values. It does take many years for you to understand and interpret full blood work, but just know some. You don't need to know all of them. Some, I'll go back to that one, but the big 4, I think, is a good start. So knowing PCV, knowing total solids. There's a chart here from VetGirl that I found that was very helpful. I don't know what time. I didn't get my phone. Where am I? What time is it? 3? I have time. Okay. It was very helpful for people who are learning. Also, I specifically put a PCV that's icteric here because that's important information when your assistants are reading out the tubes, that they know that that's something that to be aware of. Another part of the big 4 is blood glucose, which we talked about before, and lactate. So start out with those and then start to go into sodium, potassium, base excess, like little by little build out your knowledge, because knowledge is power and it'll help guide the care for the pets. I wanted to share this pretty cool blood gas from, not that pet, that was an image I got from online. So that's not a real ICU patient. This is Gigi's blood work. And Gigi, I guess, do you guys want to read that blood gas? Should we make them do that again? All right, so what do we see here at this blood gas? So the dog Gigi, the real one, not the one in that photo, was walking around having the best time of her life. Unaffected by anything. So what do we see on this blood gas? Yeah, bad, right? I've actually never seen one that low for an animal walking around. In actuality, the first time I poked her, it was 6.8. But they made me poke her 2 more times because they didn't believe me. But it was 6.8. What else did you see? Where is it? Yeah. Yep. What else?
How's the CO2?
That's low, right? Normal's 35 to 45, right? What about that sodium? Gigi was not having a good day. Anyway, it was, so a few people asked me, what was wrong with her? And I was like, honestly, I was just coming in to do nursing care. I didn't want to be sad, but what I overheard was coagulopathy. I only poked her. I didn't actually take care of her. When I ran and that's how it goes, right? In the ICU, in the clinic, like, can you just poke this animal? And then you get the stuff and you're like, what is this? What's happening with this patient? And they're like, oh yeah, she's not doing good. Yeah, I don't get surprised by a lot these days, but, and then, so another pro tip is if you have a hypoglycemic patient, knowing your dextrose bolus doses. There's nothing more satisfying than showing the doctor, hey, the BG is 23, and they're like, ugh, like, I have the dextrose, would you like me to give it? It's so rewarding because it really makes you feel like you're actively a part of that care team and you're using your critical thinking skills. All right, going to number 5, we're halfway there. Monitoring vitals, that's a huge part. This is what our electronic medical record system looks like. We have one page where the treatments are signed up, and on the other side, the values are in there, and then there's another sheet that tells me who's doing the work, so I can see which staff members are completing the vitals. So that's an important thing if you're a manager. This is good for accountability. When last summer, I want to say it was last summer, I was asked to go to Ecuador to go do some lectures at their emergency clinics. And I walked in with my friend and they were rounding. We were doing their ICU rounds and they were talking about a hypoglycemic patient. And there was a lot of, like, you could tell people were having tension. So I talked to my friend and I said, what's going on? He's like, oh, we can't get the doctors to use the EMR system at its full capacity. And unfortunately, this animal was hypoglycemic at 4 a.m., but we don't know who found it. They wrote it, but we have no documentation as to who did it, and nobody's confessing. So as much as we want to just encourage psychologically safer environments, sometimes other people aren't on the same side. So this kind of system is really good to help prevent that. And then when they found the animal, when they finally realized it 4 hours later, the BG was even lower. It was like 40 and then 28. So it's like little things like that this is why we have this kind of system. This is why we have checklists, because it's really impossible to remember it all, especially if you work overnights. Anyway, vitals. So what am I asking for during rounds? I'm asking if the animal is being weighed, has it had any weight changes? Make sure your doctors have call orders in that section so that you're not kind of just taking weights mindlessly. Temperature, I need to know, just recognizing that temperature like 98 in cats is normal if they have kidney disease. Don't ring the alarms. I like bulldogs to be 97 degrees as well so that they're nice and comfy. Is that okay, or do they have to be 99? 98.9, okay, excuse me, 98.9. And then documenting whether you're doing the ear temp versus rectal temp is important for consistency. Don't rectal cats, please, unless you have to. Perfusion, noting that in the records. Voids, so it's important for you to ask just the basic husbandry questions. I feel like sometimes we get so advanced that we forget the basics. Did they pee? Did they poop? Are they having diarrhea? Did they vomit? Did they regurg? This stuff is important because that's a lot of the time what they're presenting for. And then we find out all the other things that are wrong with them. Respiratory rate. I want to know if there's anatomic disease. So is this animal breathing weird because it's a Frenchie? Or is it breathing weird because it has, bronchial stuff, internal medicine things? Sophia, who's our internal medicine manager, would probably know more about that than me. But like some of them live with normal respiratory things. And then if it's intubated, I obviously want to ask all the questions that I told you guys to ask before. So moving on, number 6, pain score and assessment. It was briefly discussed at the previous lecture. This is so important. There are many systems you can use. Samantha mentioned the Colorado pain score system. This is the modified Glasgow composite measure scale. It's very easy to use, very basic questions. Again, a number system. The number will give you, whether this animal, we recommend that it really needs pain meds or no, it's fine. So whatever system you guys use as a hospital, just pick one and try it out, okay? It's better than nothing. And my pro tip here is to become familiar with different pain score systems and management plans. A lot of us were trained how we were trained, and when we enter a new hospital or if we work with a new colleague and they have a different idea of pain medications, sometimes we're a little resistant to it. Educate yourself. Okay, you're into ketamine steroids? Tell me more. Tell me more before you attach it to my patient. And be comfortable with doses. I can't tell you how many times new people are unfamiliar with the doses and the math, and then we realize that we were overdosing animals by accident. It's good for technicians to be those second set of eyes when our doctors are just doing way too much all at the same time. I think I know the dexmedetomidine steroids by heart for a 10 kilogram Frenchie. Like I could just make it like without even doing math. That's pretty cool to know that stuff. Don't do that. Do your math on your calculators. Oh, here's the Colorado pain score that Sam had on the other screen. I think it was a little smaller, so this is bigger if you guys want to take pictures. It's also available online. Nothing is good? Okay. Another one is the feline grimace scale. Have you guys heard of this scale? So there's also an app for it. It's actually pretty cool because it's a visual way of looking at whether we think an animal is in pain. I think it's very helpful for kitties. I looked at number 2 last night when I was just looking at my lecture, and that's what my little kitty Agnes looked like toward the end, so that made me sad. But, you know, you're so busy and you're not thinking about it. If you're using this checklist, you could be like, oh, wait, did I miss pain? She was on pain meds, but she wasn't like that after the pain meds. She was happier. But it's a good tool, and like I said, it's on your phone. And I know that my lecture didn't include a lot of exotics, but we do have a very busy exotic patient population in our ICU, and I meant to update this lecture to include that, but I just want to share that we have some grimace scales for rabbits, ferrets, rats, and some other animals as well. Hang these around your hospital. When AHA came to audit us, because I hung this up on the wall, we got a lot of points. So if you have AHA inspection coming up, I recommend putting this up there. We lost points on labeling the chlorhex, so it evened out. So label your chlorhexidine too with all the biohazard stuff, pro tip. Okay, moving on. 7, mentation and ambulation. I think my pro tip is there, but so Samantha also talked a little bit about this, so I'm not going to go too far in. This is the modified Glasgow Coma Scale that was shared earlier. What I want to talk about here is that there are considerations when you're asking in your rounds about mentation and ambulation, right? If you have a 17-year-old Chihuahua, it's not going to be running around. It's going to be a little quiet. That's something that you should take note of. It's a husky. I've seen huskies that are healthy, and I've seen huskies that are sick. They all scream. So, look at the whole picture, right? What I do want to talk about here is I've noticed that when I'm training a lot of new technicians, they don't really understand the definitions of the words, usually obtunded, stuporous, and comatose. It's hard. I don't think I even know them. I start off with, okay, that's normal, but if it's not normal, I go to my criticalist, usually Joel Weltman, I go, what's this? And then he gives me the answer. So printing that out, if you have a little rounds book, just so that you can at least read what the definitions are, will help you. And you should also have this as a part of your treatment sheet for your patients that are admitted. So ambulation is another part of it. So I usually don't have the pictures there, but I guess I gave it away. So the most common animals that are non-ambulatory in our ICU are going to be our neuro cases, whether they've had surgery or whether they are TBIs or got something else going on with their brain on fire, and the ventilator patient. That is like the number 1 patient that is non-ambulatory. And so tip number 7 here is something that I get very passionate about, and I'm surprised that I'm not all riled up already, but the tip number 7 is prevent decubital ulcers and urine feces scalding. Do you guys know what that is? That's when animals lay and pee and poop and we're not really bathing them as much as we should. Don't let me see you do that, because that really pisses me off. Like, being an ICU tech, this is the bread and butter of it. It is husbandry. It is not how many central lines you can place. It's not how many ventilator settings you know. It's not how much pathophysics. It's literally being a care technician for your patient. So I always tell them, I don't care if he's had diarrhea every hour. I expect you to bathe him every hour. Because once you get decubital ulcers, you're not getting back from that. And it's really unfortunate to have to deal with that when you've done all these life-saving therapies. So utilize your team. If it's not you, delegate it to other people and take turns. But this is such an important part of patient care, and the thing that really just gets me all riled up. And then I'm not going to go through this list because Samantha did a pretty good job with it, but make sure if you have a patient that's not ambulatory or has poor mentation that you have this whole checklist of things that you're doing every, I think it's every 4 hours, right? 2 to 4, yep. All right, I guess I did get worked up. Okay, number 8, we're almost there. Nutrition. Who knows this reference? Who's our age group? Oh, amazing. Who doesn't know this reference? Yeah, half you didn't raise your hands. Don't lie to me. Okay. So this is from an old movie. So nutrition is so important. So what do you ask? Is your patient eating? Yes, great, amazing. What is it eating? How much are we, is it a quiet eater? Does it like to eat at night? Is it a social eater? For cats, pro tip is if the cat's not eating the wet food, try dry food. I can't tell you how many times I walk in and they're like, it's not eating. And I go in with the dry food and I feel like a hero because the cat just goes, starts eating. And I'm like, all right, this is great. Okay, no, if it's not eating, that's a problem because now we have to deal with it. So is there an anatomic reason? Does this animal have a jaw fracture and it's not going to eat? Does this animal have really, really bad dental disease and it's not going to eat? Although I've seen a lot of animals with bad dental disease that don't eat. Recently, something I didn't think about, especially after dealing with my own cat, was cancer. So she had squamous cell in her mouth and she couldn't eat. And I didn't think about that when I was lecturing about this. So that's another consideration. And or is there a systemic reason? If you have a cat with a creatinine of 19, it's not eating, right? Tubes. So there's all sorts of tubes that we use in our hospitals, NG tube, NE tube, E tube, PEG tube, and then allergies. That's a good consideration. Our clients are very in tune with their pets. We're in New York City. They all have all sorts of fancy diets. They're clients that are very just passionate about my animal can only eat rabbit. Believe them, because they're the ones dealing with the diarrhea at home. I have an Aussie, and let me tell you, it took me like 2 years to figure out what wasn't gonna give him diarrhea, which was all over his feathers. So if they're telling you they have chicken diet, don't give them chicken. If they're telling you they have whatever, allergy, don't do that. Try to give them what you can, or what they're supposed to eat. I do have a podcast that I recorded talking for 30 minutes about nutrition if anyone's interested. It's on Veterinary Anesthesia Nerds. So why do we care about nutrition? Well, when we don't address it right away, we increase morbidity, mortality. That is literally the scare factor for anything that we do. We want to catch it very quickly so that our patients don't decompensate. So when I talk about nutrition, I ask people, if you're unfamiliar with something, just go to the basics, the why, what, how, and where kind of thing. So why do animals not eat? Typically in the ICU or in general, they don't eat because they're nauseous, they're in pain, they have anxiety. Back in the day when we didn't have electronic medical record system, it was because sometimes the doctors would forget to sign up the orders. It doesn't happen as much, but if you're not using EMRs, that's a consideration. So what are the different types of malnutrition? Stress starvation, so loss of lean muscle, due to disease states, so something like kidney disease, or it could be simple starvation. There's no disease state, but they have inadequate food intake. So I gave an example of what stress starvation would be. So if an animal has like significant kidney disease or maybe a DKA, but what's an example of simple starvation when there's no disease state? Yeah, so there are 2 different states for starvation. One is stress, so you have some sort of ailment, like you have diabetes, you have kidney disease, maybe you have heart failure, maybe you have a collapsing trachea, so you're not eating because you're trying to deal with that. But then there's another reason that animals are starved. Yeah, I gave the answer right, neglect, so cruelty cases. Yeah. So they're knowing why this animal looks the way it looks and why it's having malnutrition is important as well. And I think we're all familiar with refeeding syndrome, and that's a pretty delicate thing to navigate as well. I'll figure out how to ask that question better next time. So who are we worried about? Any animal that's not been eating for 3 days is already at risk. And when these animals come in, how long have they not been eating? 5 days, 7 days. So yeah, just last week, it's been a week. So we're usually already behind the ball. So we want to address it pretty quickly. How do they eat? Well, there's a few different ways. They can eat via mouth. They can eat IV if in the hospital, or a little bit of both. But always offering by mouth is the best way. So here's another audience question. So why do we care about nutrition? Why do we care that these animals are not eating? What are the consequences, the actual consequences on the body? Yeah, so anorexic is not eating at all, right, everyone? Hyporexic is low appetite. Yeah, like hypotension, hypothermia, like low. Yeah, of course. So what happens to the body? Yeah. Slow metabolism, yeah. What else? Yeah, lots of different things. I'll skip through because I don't know what time I am at, but I want to make sure I get through. So impaired immune system. So your body's not able to fight off things as normal. Bacterial translocation. I don't know if you guys remember that from tech school, but that's pretty bad. If your bacteria is supposed to be in your intestines, in your gut, and it translocates, meaning it moves, where do you think it's going? Into the body, right? Sepsis, SIRS, MODS, death. Altered drug metabolism. I'm giving all these drugs, but the animal's not responding. Well, because it has altered metabolism, which is what I just said. And then impaired tissue repair. This is important for our post-op patients. Why aren't they healing? Oh, their albumin's low. We got to give them albumin so they can get through that post-op splenectomy. And then we got to get them to eat as well, because nutrition gives you all the things you need for life, glucose, all the electrolytes. This cat was the first CPR I did. This is me, baby Feliza, truly baby Feliza. I think this was my first or second week on overnights. And everyone was doing CPR on a bulldog in the ER, and they left me and the new intern. I think I started like in August or something when the new intern started. They left me alone in the ICU. And this cat coded, and I was like, oh no, what do I do? So me and the intern, we looked at each other, we were like, we gotta do CPR. And so we did like the first round, and then the team came back and they were like, what's going on? We're like, we don't know. And they took over, and the cat is obviously doing fine and started eating the next day. But that was a pretty amazing experience. This dog was high. So what are the options? Oral is best. If the gut works, use it. Do not syringe, force feed animals. If I ever see you do that, I'm gonna smack it out of your hands. Don't do it, because it's just not worth it. We have some little tricks that we use. So we have Entice, which is not a long-term thing, but we do have that, and that's an appetite stimulant. I don't know if you guys are familiar with it. Churu, everybody eats churu, no matter what, no matter how sick they are. And then you have the chicken and the tuna and all that kind of stuff. Then we have the tubes. So we have the NG tubes, the NE tubes, the gastrotomy tubes. So this is tip number 8. So my tip for you guys is to educate yourself on feeding tube anatomy and function. I will share a scary story. So this is an important, so as you're getting rounds, you're supposed to be asking, is the animal eating? And you're going down these lists of things. And it's important for you, if you are told that an animal has a feeding tube, that you understand how to use it. And if you don't understand how to use it, I hope that you work at a facility that has trainers or someone that explain it to you, or textbooks, or the internet, or ChatGPT. We have so much technology now, there's no reason for you not to know. So what happened in this situation was we had someone that didn't know how to use it, who asked someone else who kind of knew how to use it, but didn't really share the right information. And then the wrong tube was used, and it ruptured, and it caused really bad effects on the pet. I believe the pet died. Do not touch things if you don't know what you're doing, okay? It's not worth it. All right, so that's the last thing I get passionate about. All right, so number 9, let's go home. So tip number 9 is understand disease process and end goals. Understand what your goal is. Is the goal that the animal has diabetes, it has DKA, and the owners want to get the blood work back to normal, get the ketones out of there, and they want them to just start eating a little bit because they'll handle the rest at home? Or is the owner like, no, I want my animal fully eating, I can't manage it at home? It all really just depends on what the client's goals are as well. So some of the questions I tell people to ask are we waiting for blood work to normalize? Are we waiting for a procedure? So is surgery out all week and we're waiting for surgery to happen next week? Is our cardiologist out of town and we're waiting for an echo? I feel like these aren't that many issues nowadays because there's so many facilities that have these services. Are we waiting for vitals to normalize? We can't get that heart rate down. Are we waiting for this animal to eat on its own and not be vomiting or not have nausea? Is our pain unmanageable? I will never forget a Dachshund that we were treating many, many years ago, and it came to us for back surgery, but it had already been so painful. I don't remember the history, but it was on everything, like every CRI you can think of, every oral medication, and the poor thing had so much wind-up pain. It just kept rolling, and just the owners would come visit. It was trying to bite everyone. The owners were hysterical. We were hysterical because you could just tell this dog was so painful. That's a reason that the animal is going to stay, right? Some owner considerations. So it always seems to happen that something happens when there's a wedding, you know, and they got to go out of town and they don't really have anyone to take care of it. Okay, we're just keeping them comfy. That's good to know. Or is it a hospice situation where it's not going to be a good outcome, but the family is having a hard time processing that and grieving? Sometimes it takes a few days to come to the reality of, I can't deal with this. I know from my own cat, I knew that it wasn't good, but I just needed 2 days. I just couldn't make a decision. And so we have to be mindful of those things. And I think if we ask those questions, it will combat fatigue when you're feeling like, what are we doing here? Why are we doing this? And we all have those thoughts. I know we shouldn't, but we all do, and that's the reality. If you connect it to the human part of it, and remember, this is someone's pet. And yeah, this is really crappy that you're dealing with whatever you're dealing with, but maybe they're just not ready yet, but they will be, you know, in a day or two. And there's also DEI reasons. So I always like to mention, I know we have our opinions when we feel like an animal should be euthanized and we don't understand. A lot of cultures do not believe in euthanasia, and we need to be respectful of that, okay? We all heard that? So we don't judge, we respect. Okay, so number 10, we're almost there. TLC. So don't forget about TLC. Hopefully you have if you have an ICU or inpatient ward, you have a place where animals can have some quiet time, where there aren't people running around. I know some of my team members used to play jazz music at night, or just like rain sounds and things like that. Petting. You know, I know we're so busy, but petting the pet is good for you and is good for them. Giving them comfortable beds. Getting laundry. I know laundry sometimes is a little hot topic for us in the hospital, but just making them as comfy as possible. If an animal just had back surgery, make sure it has bedding. Don't just put it on like a paper, you know, whatever, a paper thing. Reflection. So as you're working through the ICU, as you're working on all these patients, you know, it's okay for you to reflect at home and just think about, wow, that was a really hard day. I don't know how I got through dealing with all these pets, and you know, that really sucks. I was working 10 hours and all of a sudden he just crashed. Think about it. It's okay to think about it. Grief, it's okay for you to grieve the pets that didn't make it. I can tell you there's a lot of pets that I think back on and I'm like, damn, that sucked. Or maybe I should have done this and maybe I should have done that. It's so easy when you're in it to just forget about those things and just keep moving on. It's like that dark humor, but it's gonna catch up with you eventually, and it's gonna come out in ways that you don't imagine. Social worker. We're very lucky at the AMC that we have social workers on site that are available to the clients and to the staff if needed to process cases or just outcomes that nobody was a fan of. Be kind to yourself, or be kind to yourself is my next point. So when we talk about TLC, oftentimes we're talking about the pets, right? We're talking about just making things comfortable for them. And what I want to talk about here is not that. I want to talk about you guys, the technicians, the people that work with these pets every single day, whether it's in the ICU, whether it's in the clinic, you know, there's so many scenarios. I want to talk about taking care of yourself. And I did steal this from the Norcus textbook about healthy coping mechanisms. Whether you're a surgery tech, whether you're an exotics tech, whether you work at Veg, wherever you are, I know there are days that you're stressed out. And you're just like, what is this feeling? Why do I feel rage? Well, there are some healthy coping mechanisms that you should use. And some of the ones that I enjoy, if you have the Norcus textbook, there's a whole chapter on this, but some of the ones that are my favorite are ensure you stay hydrated. Guys, I was so stressed out recently that I gave myself Pilo because I wasn't drinking water. I always thought that was a lie when people would tell me your kidneys, and then it happened to me and I was like, oh my gosh, this is true. And now I notice how much I don't drink water. So now I try to have water with me at all times. because I'm afraid to go through that again. But having water is an important part. I know it seems simple, but it's good advice. Get sleep. Don't scroll. Don't doom scroll on Instagram. Like literally put your phone in a different room so that you're not paying attention to your phone. If you work 3-day shifts, 4-day shifts, just try to be strict with yourself. All right, at 10, I'm just going to shut it off and I'm not going to look at it. Learn to say no. That's a big one. When I was in ICU, I was a yes person. I still am, but now with boundaries. So I would just say yes to everything. Yeah, I'll help with this. I'll do this. I'll do this. I'll do this. And when I didn't realize that I was taking on too much, and it wasn't the person who was giving me the task's fault because they were dealing with their own things. They didn't know what I was dealing with because I didn't speak up for myself. And then I became very overwhelmed and I would just explode. And I would just be like, I can't believe nobody cares. And that really wasn't the truth. It was just that I kept saying yes and I wasn't communicating. Actually, I have these 10 things to do. What would you like me to do first? Or I'm happy to do that, but I can't do it right now. Use your words, guys, okay? Make sure you're communicating. We're all a team. Not everybody knows what's going on with you, even though we think that they should. And then reserve, oh, this is my favorite, especially now I'm in leadership and I've led many different teams, not just at AMC. We have high tense jobs. Sometimes some days are worse than others. Reserve your life energy for worthy causes. Choose your battles. Not everything is a fight. Not everything needs to be like, they need to apologize to me. What they did was wrong. How could they not see it? No. Just take a moment, take a breath, and really think about what the root cause of what you're feeling is. And then try to work through that. I hope that you work at places where you have leaders that are invested in the why and supporting you. Here's some other things that Norcus recommended to combat compassion fatigue. So taste. I know that when I have a stressful day, I love to eat pasta. I think Italian food is my favorite food in the entire world. My best friend is from Italy. She cooks for me a lot. I love tiramisu. I love Pinot Noir. Smell. I love flowers. One of my old leaders, Liz Rush, used to always give me sunflowers, my favorite. Seeing, go see a show if anyone's into bands. Go see a funny movie. I watch Schitt's Creek on replay sometimes for no reason. Touch. I love to go to the spa or go for a run. Some people are runners. People love that physical exercise. And sound, yep. If you like, I've been picking up the guitar again recently and been enjoying that. Work-life balance is so important, guys. It is, what I want to point out here is that being kind to yourself, self-care begins with you. Clarify your personal boundaries. We're all trying our best, but we're all but one people, and we can't do it all. Take positive actions to change your life. If you are unhappy somewhere, you have the power to change it, okay? Don't bring that toxic negativity into the environment because it's just gonna ripple. If you're unhappy, make changes and speak up for yourself. I enjoy my staff members that stand up for themselves because it shows me that they care, even if I disagree, okay? Take positive actions, like I said, to change your environment and learn about positive intelligence. So positive intelligence is a course that I took. It talks about emotional intelligence. AMC put me through a course last year and it really changed my life and it really helped me not get so, just to try to get the whole story, and not get so reactive, especially as a leader. And okay, so if you're more science-based, you're like, okay, Feliza, you're telling me to go to the spa. I don't do that. Well, if you work too much and you work overtime, there's actually studies that show that if you're working over 55 hours in a pay period, you're gonna be at higher risk of 55 hours a week, not pay period. You're gonna be at higher risk of cardiac disease and negative effects on your immune system. Does anyone here work overtime or 2 to 3 jobs? Yeah, story of a vet tech life, huh? Okay, and so yeah, tip number 10, just to bring it home, is please remember to take care of yourself so you can take care of others. And that includes your patients, your loved ones, the people that you care about. There is no one like you. There is no one to replace you. You are your only you. And if you don't take care of yourself, that would be a really bad thing. We would all miss you. So remember to take care of yourself. I like to share this little photo of a plant that my boss gave me when I started my job as a leader. I was a little scared because I kill plants. I still kill plants. I don't have the green thumb, but my partner does. My apartment is filled with plants now. But I got this plant and I was like, oh God, what am I supposed to do? I knocked this thing down so many times because it was just in my way. And I think around that time I was talking to my therapist about something about just like, the stress of leading big teams and just making sure that I was able to balance work-life balance. You know, it's stressful, right? My previous team was 80. Now I have another 80. It's going to get bigger. It's stressful because you care so much about the people you're with, and there's so many stories attached to those people. It's not necessarily the work, thankfully. So she said to me, all right, Feliza, this plant's you. I was like, oh God, no. She's like, you have to take care of this plant, because if this plant dies, that means you're not taking care of yourself. And I'm like, great. So what I ended up figuring out, and this is the second photo of the plant, was the point that she was trying to make was that I can't do it alone. I need to ask for the help around me, and I did. I was struggling, and I said, I need help. And that's when all the people came in to say, all right, well, you need a little lamp, you need this, you need that, you need to water it. And I didn't have to do anything. I just had to ask for help, and help was there. So I implore you to ask for the help around you. If you feel like you're drowning, you feel like you're overwhelmed, you feel like you don't have support, there are people out there. And then here is a photo of what that plant looks like now. And it's currently maintained by my new team. So my new team repotted it, and I hope to continue that journey of this plant, and it's even bigger now. So yeah, tip number 10, the most important tip of this whole thing is just to take care of yourself so you can take care of others. And thank you, everyone.